We're live. All right. Welcome back to Fertility Fact or Fiction. It is the 22nd of June. We are excited to have you all back. Another amazing show for you guys tonight. So welcome aboard. If you're new to us, this is the show where we talk about all of the newest data and sometimes older data, reviewing topics that are interesting for you and for me. To go over and help everybody make their fertility journey a useful and productive one, and hopefully an efficient one as well. And we reveal all of the truths that need to be revealed and dispense with all of the nonsense. So we'll tell you if it's a fact or a fiction, and we go through each topic individually, and then we answer everybody's questions live. So usually we spend a few minutes just letting everybody come on board, and as you jump on, we'll say hello to some friendly faces and go from there. And we've got some cool tech this week as well. So we're going to actually screen share the studies at some critical parts because I have some tables and a graph and so on that I want to show you. So we'll go over all of that together. And then we can kind of talk about the data in a sort of hands-on, more visual capacity than we normally do. So this is going to be really an amazing opportunity to share this information with you guys. And I've been talking all day, so if I sip my tea, please forgive me. It's green tea with jasmine. So this is an antioxidant for those of you that are going through fertility therapy. This is the stuff you want to be drinking. And I guess Tarek from IG Strategies Group is going to be asking me questions, or am I going to be asking questions?
I got a bunch of questions for you.
You got a bunch of questions for me already. All right. Okay. And I don't see, is it going to show us if people are logging on the chats?
Yeah, it won't show they're logging in, that they're...
It'll just come up with their questions.
What up their questions.
Okay.
And remember,
awesome.
You can push...
Yeah, to show it on the screen. Yeah, that's going to be cool. We'll do that too. All right, well, I hope you guys have all had a good week. I'm in Windsor, Ontario, where they are still in the midst of keeping us in phase 1. So we have not fully reopened, but we are getting very close to fully reopening. And Toronto has now gone to phase 2. So we anticipate that the province is gradually moving back towards a sane and rational approach to things. So thank you all for your part in this and for managing everything so far. Is this little dangly guy supposed to be plugged in?
Yep. Yep. That's for yeah.
The audio.
Yep.
I thought so.
That's serious.
Technical issues is a huge part of what we do here. So.
It's what makes the show exciting.
Yeah, it does make the
show exciting. And your mic is on?
My mic should be on. Yeah, I got the green light. Are you good?
Yeah.
All right, perfect. Okay, so officially, welcome back to Fertility Fact or Fiction, where we reveal all the truths and empower you to make good decisions for yourselves on your fertility journey. I want to put out a disclaimer. I don't think any of you should have to make your own decisions on this journey. That's our job, to know what we're doing and to provide you with the information so that you're automatically empowered to make a good decision. I think that we should be helping you on that journey as fertility specialists, but unfortunately, a lot of the time, patients are going through treatments or, sort of being given information that's not always necessarily optimal. And when it's not optimal, it's kind of hard to make sure that we are giving you the best information that we can each time. So we want to make sure that we're doing a good job of doing that here. That way, when you go to see a fertility specialist, you're already armed with the tools you need in order to make good decisions and be able to navigate your journey your way. On one of my recent posts, I said that cookie cutter medicine really doesn't fit in the infertility world because we are making babies. We're not making cookies. So make sure you're going to a center that's taking care of you, that can address your questions and answer your needs specifically, because everybody's journey through infertility is different. And we want to make sure that your journey is unique and it's yours. So no one should be forcing you to do something you don't feel comfortable with, and certainly no one should be making you do anything that isn't right for your particular situation. So along those lines, we did get a really interesting question, and I want to address this before we get into the fact or fiction. on a patient from our YouTube channel that asked about having her tubal reversal done after she had had an endometrial ablation. So I've got to explain some various parts to this. So let's begin with the tubal reversal. We've discussed that on the show before. In fact, just a few weeks ago, we had a comparison of IVF versus tubal reversals depending on the patient's age. And a tubal reversal can actually be a great fertility choice. It's not always IVF, guys. So it's very reasonable to do a tubal reversal under certain circumstances. But this patient had had one other feature, and that is she had had something called an endometrial ablation. So for those of you that don't know what an ablation is, and if you're watching a fertility show, you shouldn't know what an ablation is. It's when you have had a lot of bleeding during your cycle or your periods, and you want to make sure that you are getting rid of that bleeding and you are actually reducing the amount of blood flow and blood loss every month. So in order to accommodate that, what we do as surgeons is we go in and we burn the lining of the uterus. Now you can use a laser, you can use hot water, there's balloons, there's this microwave wafer thing. There's all sorts of different approaches to it. But at the end of the day, the reality is you are burning the lining of the uterus. The same lining that is required for the embryo to land in an implant in order for it to attach and develop. Now, no one will ever tell you that an endometrial ablation is birth control, because it isn't. That's why the patient had her tubes tied at the same time. However, it is extremely, extremely difficult to get pregnant after an endometrial ablation, regardless of whether or not you are having regular periods or you're not having regular periods. So if you are having regular periods, it does not mean that the lining of your uterus is normal. So if I were to do this, and I've only tried it once in the past after tremendous discussion with the patient, you would first have to put in, at the very least, a saline infusion sonohystogram where you're flushing fluid into the uterus to make sure the inside of the uterus is okay. And then I would further develop that by going in with a camera and doing hysteroscopy to make sure 100% that the inside of the uterus is okay. Unfortunately, this patient was told she was fine without any of those investigations because she was having periods. Well, about 20% of patients that get an endometrial ablation have no result whatsoever. And depending on what technique is used, many of them will actually go on to continue having periods, albeit a little bit lighter than they were before. So many women, up to 60%, depending on the endometrial ablation technique used, can continue having periods, but that does not mean that the cavity or the lining is normal or capable of supporting a pregnancy. So this patient, unfortunately, went through the tubal reversal before having the testing of her lining and her uterus, and is now wondering at a slightly advanced age, if I remember the question correctly, why she isn't succeeding. Well, she then went later and did something called a hysterosalpingogram. And that hysterosalpingogram is where they flush in dye to check the tubes and check the uterus. And the hysterosalpingogram could not be done because they said that there was blockage, or what's called a filling defect in the uterus. Well, of course there was, because that uterus had been ablated. So unfortunately for that patient, and I know you've been waiting patiently for about a week now for us to answer this, but we wanted to bring it up on the show so everyone had the benefit of hearing this. You did not receive the investigations you needed at the start in order to make an informed choice and make the right choices for yourself moving forward. There is no question that there is a possibility of salvaging the uterus and using it again, but very few of us would actually recommend doing it. The one time I did do it, I did manage to get the patient pregnant. I got her pregnant and she continued the pregnancy until about 16 weeks. At 16 weeks, the uterus could not stretch anymore, or an infection had embedded itself in there, and she very unfortunately went into labor and delivered the child and decided not to pursue that again. So once you've had an endometrial ablation, you never should have had your tubes reversed, because what really should have happened was they should have checked the inside of your uterus, realized there was a lot of scarring and that it was not amenable to carrying a pregnancy, done IVF on you so that you avoided the reversal, and then you really do need a gestational carrier or a surrogate for your case, it would be extraordinarily difficult to make this work for you otherwise. And I do think you have a very legitimate concern to review with your physician to tell them, why did you reverse my tubes before you knew what the inside of my uterus was like? Because that's just simply not reasonable and never should have been done in that order. They should have made sure that you were capable of carrying a pregnancy before making you capable of getting pregnant. So hopefully that kind of addresses the question that you asked. I am profoundly sorry for what you're going through. I would be more than happy to help you out in any capacity that I can, but I think it would be very challenging to get you pregnant if your uterus is damaged. At a minimum, you should see an expert surgeon who can go into your uterus and look around. And even that procedure is actually very sophisticated and risky, with a 7-fold higher risk of injury to the uterus, including perforation where we pop a hole in the uterus by accident, than it would be if you had not had the ablation before. So lots to consider, lots to think about. You need to have a long talk with the doctor that did that procedure for you. Okay, so tonight's topic is about egg freezing. And the reason that we're going through egg freezing as a topic is that we've had a change in the regulations in Canada. And because there's been a change in the regs, they're making it a lot more difficult to use fresh donors. That doesn't mean we can't use fresh donors. We can, and we will continue to do so. And in fact, we've registered and notified with Health Canada to be a center that does that. So it's something we are completely prepared to offer our patients, but they have made it more challenging. You need a minimum of 2 sexually transmitted disease screens. They want genetic testing. They want extensive counseling, a complete history, and then a complete physical as well. So there's a lot of components that we have to go through to match everybody up and make sure that it's okay. And so it's really important to be able to offer patients options, because the more options you have, the more informed the choice that you can make. So in light of that, one of the options is use a fresh donor and one is a frozen. So let me explain what that means. A fresh donor is myself and my wife want to have another child, and we feel that her eggs are not suitable for whatever reason. And honey, I love your eggs. You're amazing. We have 3 great kids. But for whatever reason, in our particular hypothetical situation, her eggs are no good. And so we're going to go ahead and we're going to use an egg donor. So we go and find Susie Q, and Susie Q is a 23 or 24-year-old. She's healthy. She's willing to donate her eggs. She goes through an IVF cycle. We retrieve the eggs. We take my sperm. We inject it into her eggs, make embryos, and we then take the embryos and put them into my wife. So it's donor eggs used fresh. We grow the embryos fresh. We transplant the first one fresh, and then we freeze the extra ones. The alternative is to say, look, we can't quite find the right person for us. Maybe Susie Q has already offered to freeze her eggs in an egg bank, just like there are sperm banks. So you can actually access batches of frozen eggs in the United States, import them into Canada, use them here for IVF, make embryos, and then take the embryos, and while the embryo is still fresh, again, transfer it in. But the eggs were frozen. So you're thawing the eggs, you're injecting them with the sperm, you're making the embryo, and the embryo is then getting transplanted into whoever the carrier is. So the question is, do frozen eggs work as well as fresh eggs do? And a lot of people that I've been talking to recently are telling me, yes, the centers that they work with, especially some of the surrogacy and donor companies, are saying that the centers that they are working with, the fertility centers, they're getting the same success rate. And I was kind of scratching my head saying, that's not my knowledge of this. So let's have a look and see what kind of success rates you can get with frozen eggs. Now, there aren't any sort of fresh versus frozen comparison studies I'm aware of to directly compare fresh to frozen, but I certainly know what our success rates are with fresh. And I wanted to kind of share what the success rates are with frozen. So there's 2 studies. So there's this one, and I'll bring that nice and close to the cameras for you guys to look at. And the lead author is Goldman. And then there's this study as well. And so this one is by Pelin Seal, C-I-L. So I'll go through each of these. There's 2 studies on this topic, and one of them, quite interestingly, actually can show you what the full sort of equation is to calculate what your probability of having a live birth is. So in the first study, they actually did a meta-analysis, and they took 10 different studies, conglomerated 2,265 cycles where they froze the eggs, and then looked at the outcomes of those cycles to determine, what the outcomes were. And as I mentioned, egg freezing is very common now. So about 50% of centers are offering egg freezing. We offer it as well. In particular for our cancer patients, it's a very good opportunity. Some women are using it to defer their childbearing or child rearing so that they freeze their eggs at a young age, hang on to them, maybe build their career or develop their career, or maybe even not necessarily career oriented. They just want time with their partner. And then they'll go back and use the frozen eggs from, let's say, their year 30 or 28 or 29 when they're now 36, 37, with the hopes that that gives you a better result. So there's a lot of this going on, and we figured this would be very reasonable to look at. So they had 1,805 patients, 2,265 cycles, and the goal was to determine the probability of a live birth as a function of age. Now, I'm sure you've heard me on the show talk numerous times about how important age is, and age is a critical factor when we're treating patients for IVF and getting their eggs out, because the older you are, the higher the probability that the eggs are of lower quality. So essentially what they looked at in this study was the outcomes of what they saw. So I'm going to run through some numbers with you, okay? Overall survival and fertilization was 85% for survival and 79% for fertilization. So those are pretty robust numbers. Now this is using a technique called vitrification. The older technique was slow freezing. Nobody does that for egg freezing anymore, so I'm going to skip that data on the slow freeze. Everybody's using the vitrification technique. And they didn't find that the age of the woman actually had an impact on the survival or the fertilization of the eggs, which is really wonderful to hear, because that means for the patients that are older, that component of it is not a huge concern. As far as the implantation rates were concerned, they saw that you had a high of 13.2% at the age of 30, dropping down to about 8.6% when you got to age 40. But they still saw live births even at advanced ages. Fewer, but they are there. Miscarriage rates did show age-related trends as well. So the older you get, the higher the risk. And it went anywhere from 19 to 22% for the vitrified eggs, depending on the age of the patient. So I'm going to share with you one of the slides. So bear with me here while we lean into some technology here. I'm going to just slide the view over, and that is the data. Okay, so hopefully for those of you watching on Instagram, we cannot do this on IG, but I'm going to explain the numbers. For everybody else, you should be able to see on your screens right now the data, and I can hold it up if I find the right table for you guys here on Instagram. So where did that table go? Oh, I'll have to find it. Okay, so in any event, there is a table showing the numbers. So if you look at the numbers here, you can see that depending on the age of the patient and the number of eggs that they got, and they broke it up into groupings of 2, 4, and 6 eggs that were either thawed, injected, and then into number of embryos transferred, they had different percentages. So I'm just going to kind of highlight the average 35-year-old, okay? So if we look at the 35-year-old, that's this line here, just above it. So if you had 2 eggs thawed, you had a 16% chance of ending up with a live birth at the age of 35. If you had 4, it was 17%, and if you had 6 eggs thawed, it was 18%. If you had 1 embryo develop, you had a 7.2% chance of a live birth. If you had 2 embryos develop, you had a 12%, and if you had 3 embryos develop and transferred, so these are 3 successive embryos, it added up to a 19.3% chance of live birth. Now those numbers are low. And so the idea that it's equivalent is simply not true, because I can tell you we get way, way higher success rates with a embryo from a 35-year-old that's done fresh than we see with the numbers that they have here. Even if you look at the youngest age group, which is up here, you can see again that in this age group here, and that's 25 years old, if you had 1 embryo transferred, you ended up with a 13% success rate. If you had 2 embryos transferred, 20.7, and if you had 3 embryos transferred, 31.5. So nowhere near what we would get from a 25-year-old. For a 25-year-old, we almost never fail at IVF. It would be highly unusual unless there's something really kind of bizarre going on with regards to their, health history or endometriosis or previous exposures or so on. So, or really poor quality sperm, for example. So typically we're going to get 80, 90% success rates in a 25-year-old. It is nowhere near 31%. So while egg freezing is very reasonable, and we do encourage patients to consider it, it's not necessarily the be-all and the end-all of every cycle. The most important thing I want to show you on this, on this graph as well, if I get rid of this guy here and just move this up a little bit, you can see that by the time you're getting up into 40, you have to transfer 3 embryos just to get a 14.8%, rate of success. So, and it drops down to 13.2% after 3 transferred embryos by the time you're at 42. So again, not robust numbers, they're fairly low. Look at what it is with just 1 embryo, 5.3% at 40, 4.7% at 42. So it is possible, and it does give women a lot of hope, but fresh, in this study at least, definitely looks better than it does in, in comparison to the frozen embryos that they're showing you here. Okay, so I'm just gonna flip back for a second, and I'm gonna go through the other study because I wanna review that one as well. So this one's called Predicting the Likelihood of Live Birth for Elective Oocyte Cryopreservation, a counseling tool for physicians and patients. And it's a great study. They looked at all the cases they had done from 2011 to 2015. There's only 520, but they included all different groups, including a group of egg donor cycles as well. So here's some critical information to know. Number one, the egg donors on average had about 16.9 eggs that they retrieved. If you were less than 35, it was about 17, so roughly the same number. And then it progressively declined. So by the time you're 37, you're at just under 15, 14.7. By the time you're 38, 39, you're looking at 10 or 11. And when you get down to over 43, you're down to 9 eggs retrieved for freezing. And in a 43-year-old, 9 eggs is actually quite a lot. We don't always even get 9 eggs from the patients. And those aren't all mature. So when you look at the mature egg numbers, it was 12.5 for the egg donors, and then goes anywhere from about a high of 14.6 at 36 years of age down to a low of 6.9 for the women greater than 39 years of age, or sorry, greater than 43 years of age. So I'm just going to flip back again, and I'll have to show our Instagram folks the graph. But bear with me for a second here while we flip over to the other study. The other one, sorry. Okay, so if I just scroll back a little bit, oh, wrong thing. So I'm going to scroll back a little bit and show you guys in the study right here. So that's a graph of your age versus your outcomes in order to be able to see what's happening. So it's the probability of having a live birth versus the number of mature oocytes. And for those of you on Instagram, we're looking at this graph right here. So these are the numbers up here, okay? So the top number up in the tallest part of the curve, this one out here, and it's a blue color, that number is for donors. And essentially you can see, if I go back into the draw apparatus here, that you have to get, they said they had an average of about 12, right? So this is the line for 12 going right through here roughly. So at that point, you're going to get, in this, they're saying about an 80% chance if you get 12 eggs from a donor. Well, that sounds pretty good, right? Like, we like that idea. And that's one live birth, or at least one live birth. But by the time you're starting to look at someone 35, let's say, or let's say even a little bit older, we'll take the yellow line, 36. So at 36, now you're down to about here. So you're down to 65%. If you get into someone that's 38, you're looking at the green line. So now we're cutting it even lower, about 45%. And when you get down into someone that's, you know, in their mid 40s or so, or early 40s, we're down in this range here, which is under 20%. Again, these numbers are not robust, and you need quite a number of eggs. In order for those patients to achieve really good success, they need to be even lower than that. Even more eggs have to be produced than just 11 or 12 in order for the patient to be able to get one live birth. So you're looking at loads and loads of eggs being produced in order to achieve a high degree of success. And if you can see up here, when I look at the top part of the graph, and I can show the Instagram folks again. So if you look up here, in order to get to the 100% point, you need an absolute truckload of eggs, 40 on average for most of the lower age groups, so the under 36, 37, and you can't even get to 100% unless you literally have over 50 eggs for the older age groups. It's impossible to get 50 frozen eggs from someone who's in an older age group unless you're doing IVF over and over and over again, or they have exceptionally strong ovaries. So frozen eggs can work, and they are a great option, in particular for cancer patients, but they are not the same as getting fresh eggs, and the success rates simply are not the exact same success rates. I'm just going to stop the screen share here, and we can flip back to there. So I do love the opportunity to have the eggs available to us in certain circumstances, especially if your particular racial background is difficult to match, or you just don't have the time to wait for a match to a live donor or a fresh donor. Frozen eggs are definitely a great option. And luckily, many of the donor egg banks will offer guarantee packages where they guarantee you a live birth. They're pricey, but in certain circumstances like this, it may be worth it to consider doing that. But is it the same? No, it's definitely not the same. The outcomes of success with fresh eggs are definitely higher in the majority of circumstances compared to what they are like with the frozens. So is it a fact or a fiction that frozen eggs are the same? It is a fiction. It is not true that frozen eggs are going to give you the same success rate as a fresh egg cycle will. You'll definitely do better in general with fresh eggs, but frozen eggs are still a viable option and need to be used in certain circumstances. So don't discount it, but also don't put all of your value and stock in that one option. There are other options for you usually. And if you give us enough time and enough effort, we can usually find those other options and make them work for you as well. So remember to like, comment, share. We always love having that. We want the questions, and we want to make sure that we're addressing your questions and your comments. So make sure you follow us on YouTube and Instagram and Facebook. And we're going to turn to the live part of the questioning now. So I'll put up a question. Are you good if I do a Facebook one first? Okay, so I'm going to put up the question, which you guys can all see now. So I was on progesterone. Let me get that out of the way. How do you get that out of the way? Right. I was on progesterone vaginally last IUI cycle and estrogen orally. This time around, I'm on both vaginally, but I'm dizzy. Can I go back to estrase orally to prevent this? That's the only, your movie thing stopped recording. That's the only thing that's different this time, just trying to avoid the dizziness. Take the progesterone vaginally. don't take the progesterone orally and your dizziness will go away. When you take progesterone orally, it can make you dizzy. And so it's better to take it vaginally. And I'm pretty confident your instructions should have specified that, because we rarely use it orally unless you're sensitive to it vaginally. So make sure you go back. One of our patients who had the ablation and the tubal reversal we were discussing at the start of the show thanked us for that answer. So you're very welcome. I am so sorry for what you're going through. Hi, sister-in-law. She's there yet. Are these embryos that have not been PGS tested? They had both, actually, from the studies. They reviewed the ones that were euploid and the ones that were not euploid. They actually demonstrated even an equation that tells you how many eggs you need in order to get one euploid embryo. And they have that data in the study. So we can definitely make sure that you guys see that. Okay, those are my questions from Facebook. Do you want to shoot from your end?
Yeah, absolutely.
Yeah, fire away. I'll take a sip of tea.
Okay.
And I got 1,000 Instagram ones here too.
What do you think of intralipids for recurrent miscarriage unexplained?
I love not miscarriage. I love intralipids for recurrent miscarriage. So intralipids is a bag of fat, essentially, that we administer IV. And through what they think is the PPAR mechanism, which is peroxisome proliferator activated receptor mechanism, it's thought to reduce inflammation in the body. The less inappropriate inflammation you have, the higher your chances of success, and probably the lower the chances of recurrent implantation failure, and the lower the chances of recurrent pregnancy loss. So I am a supporter of intralipids. We've been using it for, it's been a long time, probably 11 years now, and I love it. I think it works really well. We have used it for both recurrent pregnancy loss cases, and we've used it for the recurrent implantation failures with very good success. So I'm a believer. If you talk to my colleagues in Toronto who specialize in reproductive immunology, they will tell you that it is not as good as using IVIG, but IVIG is also about 10 to 20 times more expensive and virtually impossible to get in Canada. So intralipids is a very viable option.
Next.
Yeah.
SIS versus HSG tests, and why the SIS?
So,
is this what everyone refers to as tube flush?
Yeah. So it is what everybody refers to as tubal flushing, and the SIS should always be done. The hysterosalpingogram only as a backup if you can't tell on the SIS. So the big difference is, number one, you get way more information from doing a saline infusion sonohysterogram. You can see the ovaries, you can see the outside of the uterus, you can tell where fibroids are, how big they are they on the inside, the outside, and so on. You can see if the tubes are open, you can tell how tight the cervix is. There's a whole load of information you get from it, so it's much more informative than a hysterosalpingogram. Number two, no x-ray exposure. And number three, you're getting the tubes flushed under much better control. We can warm stuff, which we always do, which makes it painless. And in general, it's a painless procedure if done correctly. We have on our YouTube channel a live video of me doing a saline infusion sonohysterogram on a patient. And the whole time I'm asking her if she's having any discomfort, and she says no. Whereas I don't think I've ever managed to do a hysterosalpingogram on a patient who wasn't at least a little bit crampy, if not a lot of bit crampy. So definitely way better to have an SIS before a hysterosalpingogram.
I got a lot, so if you want to.
I got some here.
Right.
Hi, Dr. Victory. Is there any financing available for patients who can't afford to pay for IVF at once? Yeah, we are working on that with Scotiabank, and we should have an answer for you shortly. So there will be financing available. We don't offer it through us, at least not yet. We may at some point in time, but we haven't done that yet. But there will be financing available. So we'll take care of that for you. Let me find the next question. What's that?
Show it.
I can't. These aren't questions on Facebook. These are Instagram questions.
Oh.
If you retrieve 19 eggs and 10 are mature or fertilized, how many blastocysts are you likely to get on day 5? I'm 27. Oh, lots. 10 mature eggs, assuming 9 fertilized, 60 to 70%. So you should have somewhere between 5 to 7 blasts by day 5. Hopefully that answers that. And one more. Am I willing to work with a 41-year-old using her own eggs? Of course, we do that all the time. Had IVF at 40, 12 eggs retrieved, that's good. 5 mature and fertilized, 4 blastocysts. Oh no, I wouldn't necessarily recommend an egg donor in that circumstance. Depends on what your outcome was and how many genetically normal embryos you had, but you made enough eggs and you could potentially have a very good outcome. I've got a 45-year-old who's insisting on using her own eggs. I'm happy to try for her. She made lots of eggs. They just screwed up her cycle at another center. So we're more than happy to do it because I know I can do it in a better fashion than what she had previously. And again, we don't believe in cookie cutter medicine. So if you individualize, you can frequently get a really good outcome. You want to ask me one from your end?
Yeah, absolutely. Does doing self-infertility massage with castor oil help, especially with doing IUI?
Okay, so Dr. Jennifer Strong believes in the castor oil massages. Supposedly it's capable of helping to leach out some of the toxins. And that may or may not work. I honestly don't know. It's a naturopath thing, but if she says it works, I believe her. Having said that, I have heard of people trying to use that to unblock their tubes. That's 100% not going to work. Tubal obstruction comes from damage to the fallopian tube that actually requires tissue remodeling to undo. It's not an issue of removing toxins. That just doesn't do anything for tissue remodeling. So you can't undo tubal damage with it, but it might help get toxins out of your body. I've never rubbed castor oil on my tummy, so I honestly can't tell you, but our naturopath believes in it, and if she believes in it, I would support its use for that purpose.
Tips on how to have a successful IUI. My IUI is next week.
Okay, so the cycle should be composed of either natural egg production, which is fine, or pills or shots. So they are successful in that order. In other words, the natural has the lowest success, even if there's nothing wrong, other than male factor or cervical factor. Pills will further increase your chances, and then shots further enhance your chances. If you're doing natural or pills, you should use a trigger shot at the time of natural ovulation. We should not be making you ovulate. If you're using injectable medications, then you have to trigger when we tell you to trigger. You don't want to wait till the eggs are too big. So when they're around 18 to 20 millimeters, you should be triggered. Only do a single IUI. There is absolutely no benefit to doing multiple IUIs. It's a total scam. Do not do the double IUI or anything like that. You're just paying money for no reason whatsoever. And then obviously lots of healthy stuff. So no drinking, no smoking, no drug use, loads of vitamins, make sure your vitamin D levels are high, have sex before and after the IUI. That's what we discussed last week, and that is beneficial as well. Yeah.
Right.
Yeah.
When do you recommend starting baby aspirin before IVF, and for how long?
When do I, what?
When do you start recommending baby aspirin before IVF, and for how long?
Yeah, go on it from even a couple of weeks before and stay on it. It'll improve blood flow to your ovaries, and then just stay on it right through until you've had your embryo transfer. So aspirin, I believe in starting early, and it doesn't have to be just for IVF. It can be for IUI as well. Let me take a Facebook. Hi, here, let me show everybody this. This tech is so cool. Okay, so, hi, I received a sonohysterogram and one of the fallopian tubes could not be visualized. What does this mean? Treatment-wise, should I be worried? No, so frequently your tube can kind of spasm and close, especially if it was uncomfortable for you. Or the other tube is so open, which can actually happen at the right time of the month, that it preferentially just lets the flow out one side. So unless you have a history of damage, chlamydia, gonorrhea, ruptured appendix, previous surgeries, it's unlikely that anything is wrong and you shouldn't be worried at all. And then Jacqueline is saying, no, I am on progesterone pearls vaginally for sure. It's the estrase that I got switched from orally to vaginally this cycle, and I'm finding now I'm dizzy. Oh, can I take estrase orally to prevent it? Yes, you can take your oral estrase, although I've never heard of someone having dizziness from estrase. So maybe come back in and let's check you out, Jacqueline. But otherwise, you should be okay. Okay, that's Jacqueline. That's the same thing. Let's jump out of that one. Here, let's do this one too. Come off of there. If there is a detected abnormal karyotype in your partner when doing PGS testing, in your experience, what are... This thing does not want to jump off this time, Tarek.
Just move the mouse.
That's not working. Let's see if this will work. There we go. In your experience, what are the likelihood of normal versus not? Is it a lot higher? Yeah, so that's a great question. So if your partner is genetically abnormal, then your embryos have that further higher chance. And depending on what abnormality is, it can be anywhere from like 25 to 50%, although typically it'll be even higher than 50% sometimes. So it depends on your age, the egg age, and then, of course, the IVF cycle, how they manage it, and then the luck of which sperm actually merges with the egg and becomes the embryo, because you can't tell which sperm is normal or abnormal when you're doing the IVF. So there is a potential that the embryos will be abnormal. Those cases all need to do PGT testing, so make sure you get PGT testing. Okay. Let's do this one. Is cupping, the suction cups on the body, okay when completing a frozen egg transfer? I think they mean frozen embryo transfer. I have no idea. I've never seen any studies on cupping. Maybe Jen Strong can chime in. Jen, if you want to text us and message us, that would be awesome. But I can't see how it would necessarily be negative, except cupping does initiate an inflammatory response in your body. That's the whole reason it works. It's an immune activator. So overstimulating your immune system is not a good thing when you're doing an embryo transfer. So you do need to be cautious. Again, talk to the expert, not reproductive endocrinologist, but talk to the expert naturopath or Chinese medicine specialist who's doing that and see what their experience and knowledge of that subject is. Yeah, your turn.
Imagine, all on.
Okay, let's see what else we've got here. What's the rate of mature eggs retrieved to make it to day 5? Oh, okay, so that incredibly depends on how many eggs you've produced and what kind of cycle they ran for you and how old you are. So on average, at a very good center, you'll get, let's say, 80% to fertilize of the mature follicles, sometimes more, sometimes less, somewhere between 70 to 90% will fertilize. About 50 to 60% will become blastocysts, but it is heavily dependent on your age and all that. Your thoughts on taking progesterone vaginally versus the PIO shots during pregnancy? Can I do the pills instead of shots if going through IVF? You have to do both. So you need PIO for sure when doing IVF, the progesterone and oil injections into your butt, and you need the vaginal. That helps you get the highest level of serum, meaning in your blood progesterone, and the most amount into your uterus. So you need both in order to get an optimal cycle outcome. Just had my first IUI ever yesterday. What do you think about this study that's saying laying down for 15 minutes after the IUI helps with chances of success? So actually, we reviewed this, wow, that was like 6 months ago maybe, right? Pre-winter, I think we reviewed this. There is no benefit to lying down whatsoever, unless it's de-stressing you. So they've studied it in IVF, they've studied it in IUI. There is no benefit to staying in a supine or laying down position. You can get up and walk around right away. Do I think it makes sense to jump up off of the bed right after your partner has ejaculated in you? No. I think it probably makes some logical sense to wait a little bit, but the studies actually don't support that. You can get up and walk away. I usually tell our patients to stay, lying down for 10, 15 minutes. We're not super strict about it, and if they want to go ahead and get up, they're certainly welcome to. They can do that. Okay. Hi, Dr. Victory. We retrieved 26 eggs, which my RE said were good quality, but only 5 fertilized and 4 made it to day 5, which we froze. What might have resulted in low fertilization? That's a fantastic question. So first of all, I'm sorry that that's what you went through. That's obviously disappointing after you've had 26. So the first question is, it depends on how many were mature. You may have retrieved 26, but maybe only 10 or 12 were mature. So that's the first thing. The second part of it is knowing the quality of the sperm. And then, of course, your age and where the center was and how, well do they normally do. And then, of course, did they do conventional IVF where we're just dropping the sperm and the egg together in a dish? Or did they do ICSI where they're injecting the sperm into the egg? So all of those are really important factors, and they can contribute to getting to where you ended up with. But 4 is good, and you only need 1. Remember that. My partner just had his assay done. Normal volume, morphology, motility, but count is 5.1 million per mil. We have a prescription for Clomid this cycle and next. Chances of pregnancy with that assay count, or will need IVF? There is a chance. It's difficult. It depends on what his volume was. So 5.1 per mil is low. In general, with good sperm, Clomid and IUI is about 10 to 15% per month. With sperm down to a 5.1 count, I would probably say you're looking at under 5% per month. So that would be a realistic approach to it. Can it be successful? Sure. Is IVF a better option? It's probably a better option unless they can find a way to improve the sperm count. And there are ways to do that. Make sure there's no smoking, no drinking, no drug use, keep his testicles cool. I get all the guys to sit on frozen peas when they have very low count. You can check his hormones. You should probably get a scrotal ultrasound, make sure that there's no veins called a varicocele around it. Okay, let's see this one. So after months of conversation with our surrogate, she has indicated a September transfer would be an ideal month for her to transfer. Should she be contacting the office soon to see if a September transfer is possible? No, September would be easy, Mary Lou. We'd be happy to help you out with that. No problem. Give us a call. Jacqueline, does a dual trigger, let's do this one. Does a dual trigger stay in your system longer rather than a single trigger? Wondering if it's possible to receive a false positive after 10 days of taking the shots. Nope. If you are 10 days after your trigger shot and you're positive, you're pregnant. So congratulations. Is that the case? Let me know in your text and I won't post it. But yeah, you're pregnant if that's the case and you did a dual trigger. The HCG doesn't hang around for 10 days. It's a 5-day max usually, and then it's washed out of your system. And there was just another study, still has not even been formally published, that I saw late last night at around midnight when I was reading this stuff, which further supports the dual trigger with almost double the success rate of the single trigger. So we will be double triggering everybody that we possibly can who fits the bill for that. Okay, let's go back to here. We've only got a little bit more time, guys. So how can I know about tubal blockage? Does it require another surgery or can be done with ultrasound or CT scan? No, if you just need to find out if your tubes are open, you can do it with a saline infusion sonohistogram, the one we were talking about earlier. So just an ultrasound, or you can do a hysterosalpingogram. You definitely do not need a CT scan. That won't tell you anything. So ultrasound or an X-ray. somebody said, thank you for answering my questions. You're welcome. That's what we're here for. What can cause a tubal blockage if no history of endo or PID? So 40% of chlamydial infections can be silent. You wouldn't even know you had it. Mucus, debris, dead cells can block it. You may have had any kind of inflammatory process inside and not known it. So there's a variety of different reasons. And if you have absolutely no risk factors and they did a hysterosalpingogram on you and it was painful, then you need to redo the test with the ultrasound. Make sure they worm everything, including the fluid they're putting in you. If it's not painful, your tubes won't spasm, and that can give you a much better chance of seeing the right answer. Can high prolactin level affect male fertility? Yeah, high prolactin will suppress LH and FSH. And if you suppress LH and FSH, you're going to end up with reduced sperm production and testosterone. Someone said, Dr. Victory, it's Jess. Just wanted to say I actually have no questions, because she always has lots of questions. That's okay, Jess. We love your questions. I have high progesterone levels. What are some things I can do to help conceive? I don't know who told you you have high progesterone levels, but there's no such thing as a high progesterone level. So there are some tests being done, for example, salivary tests, which are not accurate and absolutely useless, so please don't do them. They are very expensive and of no value whatsoever. And depending on when your progesterone level is done, your progesterone level can be all sorts of different things. So there's no such thing as a high progesterone level at all, especially naturally. Whatever it is, it is. So maybe reach out to us and we'll help you through that. And if a doctor told you that, then time to find a different doctor. Okay. I've been spotting for 9 days now. Had a miscarriage last month at 6 weeks. I'm sorry. My HCG levels are negative. Should I take something to start my period? I'm on day 30 of my cycle. Get a beta HCG first. Maybe check your thyroid. I'd probably wait another 2 weeks. And then if you haven't had a normal period, then yes, definitely take Provera and it'll start it. Jen Strong messaged us, but I can't go to her without bailing out of Instagram.
Oh, it's on your phone.
Yeah, can you get a hold of her? Do you ever message her text?
No.
No? Jen, I can't answer you. Jen, sign on to Facebook and then I can see it. I can't do it on Instagram, honey. Hi, Dr. V. Just wondering what the status is on frozen embryos being transferred. First 5 arrive tomorrow. He's promised 5 per week. We're doing it as quickly as we can. I think the first 40 patients have been informed and we're going through the paperwork process. It's a huge hassle, guys. So we are waiting on it, but it is starting to happen. You will be informed slowly. This is an incredible show. Thank you. From one of my biggest fans. Does doing ICSI with IVF lower fertilization rates? No. If it's done properly with someone good, my previous embryologist had exceptional ICSI success rates. You can get very, very high success rates with fertilization. So he was getting like 90–95% fertilization rates, which are really pretty incredible. And our new embryologist has basically the same. So we're very pleased about that. My trigger lasted 12 days, but maybe ended miscarriage. Not sure. Trigger should not last 12 days. HCG washes out in 5 days, guys. So if you're positive 5 days post-trigger, maybe 6 at the most, even if it lasted a long time in your body, you should be able to go ahead and consider yourself potentially pregnant. Easiest thing to do is to do 2 betas in a row, 2 days apart. If your beta HCG is rising, it's impossible that you're not pregnant. It can't be the HCG you took from the shot because it wouldn't be going up, it'd be going down. So if you're not sure, just do a beta and then do another beta 2 days later and you'll know. Hello, retrieved 5 eggs, ICSI, and fertilized 5 with donor sperm. Only 1 made it to day 5. Any idea why a low blast rate? I'm 34. Wow. I would need to know lots more about you. So give me a call and we will happily work through it. That's really low. It could be the lab. It could be egg quality. It could be sperm quality, smoking, drinking, drug use. They have a huge impact. Weight can have a big impact. Vitamins, were you on the right amount of vitamin D? All those things. So no single answer there, but definitely lower than what we would expect. That's a low number of eggs. And that's a very poor fertilization rate, so or blastocyst rate. So something is odd there. Even genetics should probably be checked. Okay. Has IVF at the Windsor Clinic started yet? Transferring, we are starting, but we cannot do the retrievals yet because the college is refusing to come in and do inspections. But we hopefully, now that Toronto is opening, they will go back to it soon. So keep your fingers crossed. And don't forget to sign the petition on change.org for us, guys. Oh, yeah, somebody asked about this earlier. Another week, you mentioned an endo test to see if there is endo without surgery. Is that available yet? So I posted an article about an algorithm from a variety of blood tests where they now believe they can accurately detect your chances of having endo. However, it is not yet commercially available. If you go back about, I think, 3 or 4 weeks in my Instagram and Facebook posts, it's there. I'm sure they're commercializing it. God knows people don't hesitate to make a buck when they can. But to the best of my knowledge, that test is not available yet. Hi, doctor. Please, if I need to come for IUI from Winnipeg, how long will I stay? 20 minutes. You don't need to stay. You could come hang out with us for 20 minutes and you can go back literally same day. But for IUI, you really don't need to come all the way from Winnipeg. If you're coming for IVF, I get it. But honestly, IUI does not require a trip. I just want to save you the hassle and the money. But absolutely, if you want to come down, we can. If you're someone with a very tight cervix, for example, then that's a different story. I'd be happy to see you again and deal with it because I know that cervix can be tough. So you don't need to spend more than a day in Windsor. Thank you so much for everything you do. You go above and beyond. It's much appreciated. My pleasure. I think we ran out of questions. Any on your end?
No.
No? Okay. Hey. With 3 minutes left to spare. Okay, so thank you again for joining us on Fertility Fact or Fiction. We love doing this show. Tarek and I look forward to this every week.
It's the highlight of my week. It
is the highlight of my week too, yeah. Tonight we had pizza. It was good pizza, vegetarian, from, where did we get it from? Antonino's. Yes. Tarek picked up amazing pizza up here in Windsor. We love you guys. One last quick question. Does Metformin make you B12 deficient? Ooh, that's a good one. Not that I'm aware of, but it's possible. Now there's a ton more questions. Guys, you gotta tell me or ask me questions later, but I will answer. If I have a history of ectopic pregnancy and a rate increase of having another one, is IVF a good idea to do? One ectopic, you don't really need to do IVF, but if you've had 2 or more, it's definitely worth considering. Okay, signing off. Believe it or not, it is almost 9 o'clock. And at 9:15, I have yet another appointment with a patient. So it's been a pleasure. As always, remember to like, comment, subscribe, especially on YouTube. All of you following us on Instagram and Facebook, help build up our YouTube channel. Follow us there. Tell all your friends. Make sure they watch. The more people we get on this, the better we can make it. And I've got an interview this Friday with someone that runs a blog for about 5,000 women who are a little bit older and are going through fertility problems. So they've seen what we do here on the show and they're interested in interviewing us. So hopefully we'll be able to reach many more. All of you stay safe, please. God willing, we're going to pull out of this COVID thing soon. And thank you for all your support. Have a good evening, everybody. Take care. We'll be in touch soon. Bye now.